Good morning, everyone. Can everybody, including the people in the back, hear me okay? And can you see me okay? I have to kind of stay here, I think, in the view of the camera. I tend to walk around a little bit, but I'm going to try to stay put for the most part. I wanted to start by saying thank you to Rachel and the rest of the NMNPC conference organizers. This is my second conference. It's a fantastic conference, and it's an honor to be here with you today to talk about anticoagulant adverse effects. And this is an important topic to talk about because currently in the United States, there's about 8 million people that are on anticoagulants. This has gone up exponentially since the advent of the direct oral anticoagulants. And this number is expected to at least double by the year 2050. So if you're not already, you're going to be taking care of a lot more patients on anticoagulants. So I always like to start by asking how many people in the room are anticoagulation experts? Raise your hand. All right, whew, I'm relieved. Takes the pressure off, except for Laura McDermott. Don't ask any hard questions, Laura, okay? All right, so today we're gonna be talking about anticoagulant-related adverse effects, and we have been having some technical difficulties with our slideshow, so bear with me as we work through this. Here are my disclosures. Again, thank you for that introduction. I do want to make one shameless plug for the Anticoagulation Forum. I'm honored to be president of that national nonprofit organization. If you don't know us already, I would encourage you to go online, check out our website. Membership is free. All of our resources are free. It's a tremendous treasure trove of clinical tools for you and your colleagues. I'm going to get the hang of this in just a second. All right, so broad brushstrokes. I'm not going to read through this. Today, we're going to be talking about anticoagulant-associated bleeding with the direct oral anticoagulants, because that's what you're predominantly seeing in practice nowadays. They dominate the market with over 95% of market share. And we're going to talk about managing those bleeding events in those patients. We're also going to talk about heparin-induced thrombocytopenia, which is another common adverse event. And even though it's common, it is still very rare. The deal there is that it carries a high degree of morbidity and mortality, so we need to promptly recognize and treat that when it does occur. All right, so we're going to dive right in and start by talking about anticoagulant-associated bleeding. And the reason that DOACs now dominate the market is because of data like this. So this is meta-analytic data from all of the large randomized controlled trials comparing direct oral anticoagulants as a class to warfarin for atrial fibrillation and venous thromboembolism. And what you can see in that top row there is that in regards to efficacy, okay, this is preventing or treating thromboembolic events, these two classes of drugs are equivalent. DOACs are no better essentially than warfarin. Where you really get the bang for your buck with the direct oral anticoagulants is this significantly improved safety profile. So compared to warfarin, you can see in the column to the right, with the DOACs for GI bleeding, there's no difference, okay, as a whole. For major bleeding, we get about a 30% relative reduction. Intracranial hemorrhage, impressive, almost 60% reduction with the DOACs compared to warfarin. And then the DOACs cut fatal bleeding in half. So because of data like this and the convenience to the patients and the clinicians with these drugs, that's why they now are what you're seeing by far and away in your practices. It's interesting that at the time of these trials that had over 100,000 patients, there weren't any antidotes available for the DOACs like we have nowadays. So even though there were no antidotes, the DOACs had this inherent improved safety profile. And some postulate that that's because unlike warfarin patients who get depleted of their clotting factors over time, these patients retain their clotting factors. And in the event of a bleed, they can actually make that bleed much more self-limiting by overwhelming the inhibition of the blood thinner. All right, so the best way for you to prevent the bleed in your patients on anticoagulants is to keep it from happening in the first place. And there are a number of bleed risk assessment tools out there in practice. HASBLED is one of the more common ones. We tend to use this in our atrial fibrillation patients, but it's also been validated in venous thromboembolism patients. And you can basically use this like a checklist to assess your patient for modifiable risk factors that you can intervene on to mitigate their bleed risk. So controlling hypertension, looking at their time in the therapeutic range if they happen to be on warfarin. We know from evidence that patients have to have a TTR of greater than 65% to even derive benefit from warfarin, and if not, they're just being exposed to the harm. So if that's the case, you might get more bang for your buck by switching this patient over to a direct oral anticoagulant if they're an appropriate patient. And then huge intervention that each and every one of us in this room should be thinking about with every one of our patients is, are they on unnecessary concomitant antiplatelets? This is a hot area in clinical practice right now with a lot of evolving evidence. This is a really nice pictograph of bleeding with combined therapies. And so this is out of a Danish national registry. And what they're showing you here, starting on the far right in light gray, is patients on no anticoagulant therapy. So the bleeding rates are pretty low, but you can see they go up with age, right? So age is an independent risk factor for bleeding. If you move left to the blue bars, this is patients who are on some type of monotherapy. So aspirin 81, warfarin, direct oral anticoagulant, a single agent, right? So their bleeding risk goes up when they get put on an anticoagulant. The green bars are showing you the bleeding incidence if you have them on two therapies. So like dual antiplatelet therapy or DAPT, or perhaps an oral anticoagulant plus an antiplatelet. And then to the far left, you see patients who were on triple therapy. So this is what we used to do back in the day. We would put patients like with AFib, we'd put them on warfarin or a DOAC. And then if they needed like cardiac stenting, we'd just throw on a couple of more agents like aspirin and clopidogrel. Really, really high bleeding rates. And what we're learning nowadays is less is more, okay? So the pendulum is swinging back the other direction. We don't have time to go through all of these studies that I've cited over here to the left, but I just wanted to bring up some key clinical areas where you should be questioning concomitant antiplatelets in your patient. The first is patients that have stable coronary artery disease, no events in the last 12 months, and they might be on like a baby aspirin for that, but they need anticoagulation for atrial fibrillation. In those patients, you should be thinking about stopping that aspirin and just continuing anticoagulation alone. And that's based on the FIRE trial that I've cited there. Similarly, we've had 4 randomized controlled trials in the last 4 or 5 years looking at that triple therapy issue in AFib plus PCI for percutaneous coronary intervention with stenting. We now know we shouldn't be doing triple therapy in most patients. We can get by with a apixaban, such as from the Augustus trial, so something like the apixaban plus clopidogrel, so scaling back in that realm too. And then just 2 days ago, you guys probably saw that the United States Preventative Task Force has come down with a new recommendation saying that we probably shouldn't be using aspirin for primary cardiovascular prevention in the majority of patients. So if you have patients on anticoagulation and they happen to be on antiplatelets, scrutinize that and scale back whenever you can. That will greatly mitigate their bleed risk. Okay, so I've provided some screenshots here from a really nice reference citation that's down in the bottom right by Thomas Selly et al. This is from the Journal of the American College of Cardiology. If you had to have one document on how to manage bleeds in patients on oral anticoagulants, I would recommend this one. The point I want to emphasize with this slide is that not all bleeds are created equal, okay? A minor nosebleed that can be stopped with holding pressure is very different than an intracranial hemorrhage. So you have to tailor your approach to the clinical situation. And you can see starting on the far right over here, we typically start breaking bleeding events down into, are they non-major or are they major? And so for non-major events, we may not need to even provide any intervention. In fact, we may continue the oral anticoagulant through that minor bleeding episode. But for more severe bleeds, that would be considered major, and those are defined as bleeds that occur in a critical site, and we're going to touch more on that on the next slide, or patients are experiencing hemodynamic instability, or there's overt bleeding, or the patient's requiring transfusion. Those would be considered major bleeds. And the more severe the bleed, the more aggressive your intervention measures are going to be. So in those situations, we're going to be stopping anticoagulation. We're going to be maximizing supportive measures. And then over on the far left, for those most severe bleeds in the critical sites, we're going to be thinking about providing reversal of anticoagulant effect. But I just want to emphasize, this needs to be done very cautiously and methodically, okay? If you reverse somebody who has a baseline need to be on a blood thinner, you're going to put them into their native hypercoagulable state, and that could precipitate a thrombotic event. And we're not for certain because we don't have high quality data, but there are some signals that some of the reversal agents that we use actually have an inherent prothrombotic potential. So this needs to be done very, very carefully. So this is a really nice breakdown from that same document. And you can see starting on the far right under non-major bleeds, does it require intervention? If it's a non-major bleed and it doesn't require any intervention, you're basically just going to want to watch that patient and provide supportive care. And then if it is requiring intervention, you're going to probably stop the oral anticoagulant. If they happen to be on warfarin, you might give some low-dose vitamin K. But in all cases, we're always maximizing supportive care. So if they need anything like a transfusion or fluid resuscitation, et cetera. And then moving to our left, for these major bleeds in a critical site, which would be considered intracranial hemorrhage, okay, always a life-threatening bleed, intraocular, spinal bleeds, pericardial tamponade, any type of airway or hemothorax bleeding, and then intra-abdominal, or big problem is retroperitoneal bleeds. These, we're not only going to do all those aforementioned things like maximizing supportive care, but this is a situation where we're now going to be thinking, okay, I've got to give some type of reversal agent to stop this anticoagulant effect and get that off the table so I can focus on what else is going on with this patient. So I wanted to walk through a couple of cases to highlight some of this. And we're going to start with this 78-year-old male. He's on apixaban for atrial fibrillation. He's got a pretty high CHADS-2-VASc score of 7, so very high risk for stroke. But he's also got a high HAS-blood score at 6. And he gets brought in from his assisted living with a spontaneous intraventricular hemorrhage. His home meds are listed there. And I'll just point out that it also includes aspirin. And so for this patient, which of the following do you think would be the best approach to managing his hemorrhagic event? And we're going to just go by show of hands. Don't be shy. So how many people think we should give this guy vitamin K? Okay. How many people think we should give idarucizumab? How many people are like, what the heck is that? We're going to get there. All right. How many people think we should give 4-factor prothrombin complex concentrate? All right. I'm seeing some hands go up. And how about andexanet alpha at a high dose? Okay, we got one hand. Chris, no fair. Okay. All right, so let's walk through some of the evidence that will inform this question. So the reversal of DOACs is a little bit different than warfarin because warfarin has a really long half-life. You're able to see how anticoagulated the patient is because of the INR. But we have to remember that the DOACs have a much shorter half-life, so we got to approach this a little bit differently, okay? So when you have a patient present, like our case patient, that's on a DOAC, you have to figure out, okay, what DOAC are they on, right? In the old days, when people were on warfarin, because that was the only oral anticoagulant we had, it was a little more straightforward. Now we've got 4 commercially available direct oral anticoagulants, okay? And so you really have to do some investigating, interview the patient, pharmacy refills, chart review, figuring out what DOAC they're on because they require different reversal approaches, all right? You also want to figure out the current renal function as well as the time of the last dose, okay? All of these drugs are renally eliminated to a certain degree, and because of that short half-life, if they haven't picked up their refill or taken their dose in the last couple of days and you can determine that DOAC isn't contributing to the bleed and you don't need to give any reversal, okay? So good patient history here is very, very important. Now, if you look at that guideline I was telling you about from Journal of the American College of Cardiology, they also provide recommendations for reversal of DOACs. And you can see here for dabigatran, which is an oral direct thrombin inhibitor. You don't see it much in practice. It's not used much, but we do have a specific antidote for it. It's idarucizumab. It's a monoclonal antibody, and we'll talk more about that in a moment. For the oral factor Xa inhibitors, which you see more commonly in practice, we have a specific antidote in andexanet alpha. All right, so both of those agents are FDA approved. But there's a third agent that we're going to talk about, and it's a non-specific pro-hemostatic agent, prothrombin complex concentrate, also known as Kcentra. Okay, it's FDA approved for warfarin reversal, but we use it off-label for reversal of oral factor Xa inhibitors. Okay, so let's walk through some more detail on these agents. So as I mentioned, idarucizumab is a monoclonal antibody. It's a engineered, it's a designer drug. It basically goes in and binds to dabigatran, neutralizes its activity. It's irreversible binding, so once it's bound, it will not disassociate. And then the patient just renally eliminates that complex from the body. It's very easy to give. It's a 5-gram one-time bolus dose. It comes in a kit, and there's no prothrombotic signal, appreciable prothrombotic signal with this drug. It's not that financially impactful. It's about $4,000 per dose. That might sound like a lot to you, but we'll talk about andexanet here in just a minute. Again, idarucizumab is FDA approved, and it's recommended as first-line reversal therapy in most guidelines for dabigatran. All right, let's talk about andexanet alpha for a minute. This is a super sexy molecule. It's a bioengineered decoy Xa molecule. Okay, so it will go in and it reversibly binds the oral Xa inhibitor, whether that's apixaban or rivaroxaban. Those are the drugs that it's FDA approved for. And it's given in certain dosing schemas. And the dosing is a little bit complex. It's based on what specific drug the patient is on, what the intensity of their dosing is, and the time from the last dose. Okay, so if they've had it more than 8 hours prior, you're typically going to give a low dose that you see there, 5 vials. And if they've had it very recently, like within the last 8 hours, you're going to be giving a high dose, so 9 vials. So you can imagine if you've worked in a pharmacy or a hospital or admix drugs, it could take some time to mix up all of these vials and get these bags prepared. So there is a challenge with turnaround time on this. I think what's probably standing out to you is the cost of this drug. It's expensive to make because it is a bioengineered molecule. And the original price came in right around $30,000 for the low dose and about $52,000 for the high dose. And this has been a significant barrier to uptake with this molecule. But I did want to share with you all, actually, let me ask, how many people have worked with andexanet or have it in their hospital? 0. Okay, me too. I don't have it at UNM because we're poor in New Mexico. But I will tell you that AstraZeneca just obtained Alexion, which manufactures this molecule, and they have recently reduced the price, and it's now about 50% less. I don't know if this is going to increase uptake across the country, but it is making it a little more cost equivocal to the other agents I'm showing you on this screen. And with that, there may be some more uptake. So you may see andexanet alpha in your hospital soon. The last thing I just want to mention is this 4-factor PCC. So basically this is pooled human plasma. It contains factors 2, 7, 9, and 10. You're basically dumping a big bucket of clotting factors into your DOAC patient to overwhelm the inhibition of that factor Xa inhibitor. You can give it in fixed doses. That's what we do at our hospital, or you can give it on a weight-based, in a weight-based manner. I will say PCC has remained a workhorse across the country because of the cost of andexanet alpha. So what most hospital formularies have right now, and I have this on the next slide, is they basically have PCC as their workhorse for oral factor Xa inhibitor reversal, apixaban and rivaroxaban, and then they're using idarucizumab for any dabigatran reversal. This is based on a collective body of evidence, some of which is reflected in this graph to the right. This is a meta-analysis, okay, so we're looking retrospectively at studies that were done, 60 studies, like 30,000 patients. And what you're seeing here is on the far right, you're looking at effective hemostasis comparison between these drugs, okay? You can see there's really no significant difference whether you use PCC, whether you use idarucizumab, whether you use Andexanet. And then on the far left, you see there's really no difference in mortality either. And when you have lack of really good comparative efficacy data or no evidence that one is better than the other, my pharmacy administrator is going to say, I'm not going to pay $30,000 for a drug when I can get maybe the same effect from a drug that costs $5,000. So there's been a lot of challenges with uptake of this drug. I'll point out in the middle, thromboembolic events at 30 days with these drugs. We don't know exactly what this means yet because, again, this is all retrospective data. We don't have prospective randomized controlled trials on this. There are some pending, but what you see in that purple bar there above ADX, which stands for Andexanet, it seems like Andexanet may have a bit of a more prothrombotic signal, but again, we can't draw any firm conclusions on this. And that's why we're all eagerly awaiting a phase 4 randomized controlled trial that's going on right now, comparing standard of care, which includes PCC, with Andexanet alpha for patients that need reversal of oral factor Xa inhibitors. Until that time, what we're seeing on the right-hand side, these are maps showing uptake of these agents on hospital formularies across the country. So in the top, you see many more hospitals have idarucizumab on formulary for dabigatran reversal, as opposed to Andexanet for oral factor Xa inhibitor reversal. Again, with that price reduction, we might see these color schemas and uptake change over time. All right, so getting back to our case, I think in this situation, good job. We're not going to give vitamin K. It doesn't work to reverse DOACs. Idarucizumab is specific to dabigatran. And you wouldn't want to just blindly give Andexanet alpha high dose. You got to talk to the patient, talk to the family, find out time of last dose, et cetera, and then you can make an informed decision. So here, C, fixed dose PCC would be the best answer. All right, so I'm going to continue this case because most bleeding, anticoagulant associated bleeding talks you go to, they talk about reversal and they basically just stop there. But that's not the end of the story for our patients. So I wanted to use this case to highlight that and stimulate some thinking. So we have this same guy, right? He came in from his assisted living, had this big head bleed on apixaban. We reversed him. He's doing pretty well, actually, and he's getting ready to go back to a rehabilitation facility. So at this point, which of the following do you think would be best for stroke prevention in this patient? Should we resume aspirin for long-term stroke prevention alone? Should we discontinue aspirin and start warfarin prior to discharge? Should we discontinue both apixaban and aspirin? Or should we resume apixaban in 4 weeks if the patient agrees? So who thinks it's A? Who thinks B? Who thinks C? Okay, I see a few hands. Who thinks it's D? All right, good job. Okay, let's take a look at this. Okay, I think this is a really important question that we sometimes forget to ask, all right? After somebody has a big bleed on anticoagulation, the next question should be, is actually a few questions, right? Should we resume anticoagulation in this patient? If we're gonna resume, when should we do that? And then with what agent, right? So next few slides are gonna inform these questions. So anytime you are dealing with a patient who just had a big life-threatening bleed on anticoagulation, this is going to require a lot of shared decision-making with the patient because their preference is paramount, okay? And so you can see that along the bottom of the screen. If they place a higher value on avoiding recurrent thromboembolism, then you are likely going to lean towards restarting anticoagulation. But if they're like, no way, no how, I'm not doing that, then you're likely going to withhold resumption of anticoagulation. Other things, when you start, if you're having a more robust shared decision-making conversation, things you're going to want to think about are, all right, well, why was this patient on anticoagulation in the first place? What's their thromboembolic risk? So if they have something like severe antiphospholipid syndrome or multiple mechanical valves, that's a situation where you're going to be thinking about resuming anticoagulation, right? Whereas if they had something like a provoked VTE 11 weeks ago and they need just 12 weeks of therapy, you may not resume therapeutic anticoagulation for that final week, right? And then you're thinking about the bleeding risk. If their bleed was a nuisance bleed or mild, maybe it was like dental bleeding, or nasal bleeding, that would push you towards restarting anticoagulation. Or if you found some of those modifiable risk factors, right? Controlling their blood pressure, stopping concomitant antiplatelets. And then there are some situations where the bleeding is real scary and the risk of recurrence is real high. This would include things like cerebral amyloid angiopathy, which is the leading cause of ICH with anticoagulation. Other things like CNS microbleeds. So you want to use some sort of matrix like this when you're having the conversation with the patient and making this decision. So this does take some time and thoughtful consideration. Okay, key takeaway point for you guys today, because I still see this happen in practice. In old guidelines, we used to say, all right, if your patient can't tolerate oral anticoagulation with warfarin, you could just give them antiplatelet therapy for stroke prevention. That's no longer the case. Okay, we now have evidence that aspirin monotherapy or even antiplatelet therapy isn't really adequate for stroke prevention in atrial fibrillation. Okay, this is a change in the guidelines. It's driven by primarily by the advent of the DOACs, which are much safer, and namely this trial that I'm showing you right here. So this is an important trial for you to have in your toolbox. This is the Averroes or Averroes trial. It was conducted in over 5,000 patients, okay, where patients who were considered not tolerant or not willing to take warfarin. They were randomized to apixaban or aspirin, okay? And what you're seeing in these event curves, this one to the left here, that apixaban was significantly better in preventing stroke and systemic embolism, a 55% relative reduction, so much better than aspirin. And look on the right-hand side. There was no difference in safety between a DOAC, apixaban, and aspirin. So nowadays, if you have somebody that you need to resume anticoagulation in for stroke prevention for AFib, your first go-to should be a direct oral anticoagulant and probably apixaban. Okay, aspirin monotherapy, no longer recommended, so don't use that as your default. All right, what if our guy, we have this conversation and he says, no way am I going back on anticoagulation. He's got a CHADS2 VASC of 7. He's gonna have a big, bad ischemic stroke, right? What can we do in those situations? Well, how many of you have heard of left atrial appendage occlusion? All right, cool, a few of you have. So this is an option for our patients who aren't gonna go back onto anticoagulation. And basically the way this works, and you can see in this diagram in the upper right-hand corner of the screen, this is an area off of the left atrium. It's called the left atrial appendage. Everybody's got one. Everybody's is a little bit different shaped. Super fascinating. We don't know why we have this. It's a vestigial space. Doesn't really serve any purpose other than to cause 90% of the clots that form in atrial fibrillation patients within the heart, okay? So the idea behind left atrial appendage occlusion is taking a device. This is the Watchman Flex device shown here. And you basically percutaneously insert this and it caps off that left atrial appendage where blood flow can't get in there and create a thrombus. Okay, so this is a new option. There was a paper published back in 2020 that I'm highlighting here in the upper left. And this was done in Michigan. And this was atrial fibrillation patients admitted with a massive intracranial hemorrhage. And they looked at the discharge paperwork to see what was their stroke prevention plan at discharge, right? 50% of patients who were at stroke risk had no plan. So you just want to make sure you're thinking about this and not sending your patients out unprotected, okay? And so left atrial appendage is an option in those patients. And this is actually supported by the ACC AHA guidelines. You can see here a 2B recommendation in atrial fibrillation patients who cannot tolerate long-term anticoagulation, okay? Now, be aware, this is kind of like placing a stent or something like that. It's going to need to endothelialize over time. And so patients are going to need at least 6 weeks of some type of antithrombotic therapy while it's endothelializing. So they will still be at risk for that short period of time, but hopefully you can eventually stop that, okay? So this is just a schematic showing you kind of the overall picture of, hey, my patient had a big bleed on anticoagulation and I think I might need to resume anticoagulation. or have a shared decision-making conversation. I'm not going to go through all of this. I'm just going to highlight for our patient case. The answer would have been, let's have a conversation with this patient. And if he's amenable to resuming on the far left, we probably would think about doing that roughly at around the 4-week mark to give him some time to stabilize. And if he's not amenable, we're having that conversation about left atrial appendage occlusion. Okay. All right, so we already talked about the answer here. I just want to make sure we emphasize why the other answers are wrong. Aspirin, no aspirin monotherapy for long-term stroke prevention. We wouldn't stop aspirin and then start warfarin, because warfarin he wouldn't be easy to manage on warfarin, and warfarin has a worse safety profile than a DOAC. So if we were going to resume, we would choose a DOAC, and we definitely wouldn't want to send them out with C, which is nothing. Okay. All right. We're going to move into heparin-induced thrombocytopenia. Before I move on, let me get a time check because I don't want to be rude. I need to wrap up in about 10 minutes, I think. Does anybody have any burning questions right now? Okay, hopefully we can get to some questions at the end. So let's talk about heparin-induced thrombocytopenia. Just by these pictures, you can see it's a pretty nasty disease state. So fortunately, it's rare. But let's talk about what it means, right? So it's heparin-induced thrombocytopenia. So it's an immune-mediated reaction, and it's precipitated by exposure to heparin or low molecular weight heparin, which are shown in those little red chains there. When that gets introduced to the patient's body, it interacts with a molecule called platelet factor 4. And when those two come together, it looks weird to the body. So the body has an immune response and generates IgG pathogenic antibodies in some patients. And then that ternary complex, those three components, sometimes are of the exact right configuration to bind to and activate platelets. Okay, so activated platelets, what do? They start cross-linking, aggregating, making microemboli, okay, and leading to activation of the coag cascade and thrombosis. So this is a weird counterintuitive disease state. My patient has thrombocytopenia where I'm usually worried about them bleeding because they can't affect primary hemostasis. But in this situation, they're actually at risk for clotting. So very counterintuitive disease state. The reason thrombocytopenia develops is because that ternary complex, when it binds, when it's floating around, it looks weird to the body also. And the spleen, the splenic macrophages will go out and consume that and sequester and eliminate them from the body. So the platelet count falls. And then also these platelets are being consumed in these small clots. So the platelet count drops. Okay, so this conveys a high degree of morbidity and mortality. And we have to recognize it quickly. Now, think about it. There are lots of patients who get exposed to heparin and low molecular weight heparin, about 12 million patients a year. But HIT is rare. It's a zebra. Don't look for the zebras, right? Look for the horses. But if you do suspect this, you've got to get on top of it quickly and do an appropriate workup. Because if not, your patient's at like 50 times higher risk of having a thrombotic event than if they didn't have HIT. This happens more often on the venous side. So we want to watch the platelets, particularly in the first 2 weeks. And if we see certain signals, and particularly among certain populations, we're not able to readily predict who this is going to happen in, but some risk factors include, unfractionated heparin is the most egregious culprit. It happens in older patients, surgical patients, females more than males, and with longer exposure. So if we do suspect this, we need to make sure we're recognizing it and acting on it. So this is kind of how it presents. So again, you have to have this these clinical events, so exposure to unfractionated heparin or low molecular weight heparin, and you're really looking for this significant platelet drop, generally about 50%, that occurs about 5 to 10 days after that initial exposure, because the patient's body has to have time to form those antibodies. Okay, it doesn't happen right away in typical HIT. But if you have a patient who's been exposed recently, like in the last 3 months, they might have already developed those antibodies, right? And then when you re-expose them, their platelets drop much faster, like within the first 24 hours, which is what you're seeing on the far right of this graph. If you see a platelet count that's less than 20,000, This is rare in HIT, and you should be looking for something else, and sepsis in your hospitalized patients is the #1 cause. You can have HIT with or without thrombosis, and so you have to have this clinical presentation, and you also have to have serologic confirmation of these pathogenic IgG antibodies as part of your workup. So HIT is rare, okay? Choose wisely in who you want to work up for HIT and who you want to treat for HIT, because remember, we're thinking HIT is prothrombotic, but if it's not HIT and your patient is truly thrombocytopenic and you blast them with therapeutic anticoagulation, you're going to precipitate a big hemorrhagic event. So you got to choose wisely. Patients have lots of reasons to have low platelets in the hospital: dilution, post-surgical bleeding, chronic alcohol use, drugs, right? I'm a pharmacist, lots of drugs that cause thrombocytopenia, vancomycin, linezolid, Bactrim. So be looking for those things and thinking about those. This is a nice diagram, another nice reference for your library. This is from the ASH HIT guidelines that were published back in 2018. And basically it's an algorithm that will walk you through exactly what you need to do. And those numbers that are there are the actual numbers of the recommendations within the guideline. But what you can see here is that if HIT's suspected, the first thing you want to do is calculate something called the 4T score. How many of you heard of the 4T score? All right, good. We're going to look at it on the next slide. So if you have a low clinical probability on your 4T score, you don't need to do anything. But if you have a score that's greater than or equal to 4, you're going to need to stop heparin, start an alternative anticoagulant, order some labs. You want to put an adverse reaction in the patient's chart. So we're going to talk about an ELISA. And then if the ELISA is positive, then we're going to get some confirmatory testing through something called the serotonin release assay. So these patients definitely warrant alternative anticoagulation because they're now in a prothrombotic state. Okay, just broad brushstrokes, high level 4T score developed by Ted Workington. The 4 T's stand for degree of thrombocytopenia. Okay, so again, you're looking for a platelet count fall, typically around 50%. And the more your patient's clinical picture approximates that, the higher the points they get. And it ranges from 2 down to 1, down to no points, okay? You also think about the timing of the thrombocytopenia. Again, it's an immune-mediated reaction. Did that platelet count fall between days 5 and 10? And if they have a new thrombosis, right? If patients have low platelets, they shouldn't be able to form a clot. So that's a clue, right? And you would get 2 points for that. And then other causes of thrombocytopenia. Remember, hospitalized patients have lots of reasons to have thrombocytopenia. This is a zebra, but you got to be aware of how to do this workup. So anytime you suspect HIT, the first thing you want to do, calculate a 4T score and figure out what that is. This tool has a 99% negative predictive value. That means if you calculate, thank you. That means if you calculate a low risk, you don't need to do anything because there's a less than a 1% chance that your patient actually has HIT. All right, so we have another case. I only have about 5 minutes, so I'm going to read through this very, very quickly. So we have a guy who's admitted to the TSI after a motor vehicle accident. He's got multiple injuries. He's been on prophylaxis with enoxaparin. On hospital day 6, he pops up with lower extremity femoral DVTs bilaterally, and he started on therapeutic enoxaparin. And then on hospital day 7, his platelets plummet. So if you calculate a 4T score for this guy, you would get about a 7. And so that would warrant testing in this guy. So what would be the best approach? We're going to fast forward through this. The correct answer here is going to be, you're going to stop that enoxaparin because that's the offending agent. We're going to start an alternative anticoagulant called bivalirudin, which is a direct thrombin inhibitor. And then we're definitely going to want to order that ELISA antibody to look for those pathogenic antibodies, okay? There's some do's and don'ts in HIT. You want to stop all the offending heparin agents. You want to start an alternative anticoagulant. You got to enter that heparin adverse reaction on the patient's profile and then perform that diagnostic testing. The don'ts are don't just sit around and wait for the lab results because you need to get therapeutic anticoagulation going. Don't transfuse platelets, and very importantly, don't insert a filter in these patients because it serves as a nidus that will exacerbate the prothrombotic state. And we don't really use longer acting oral anticoagulants in these patients. We don't like start a DOAC right away in these patients, particularly if they're still critically ill, like the guy in our case. We'd probably start with that parenteral bivalirudin. And then we don't start warfarin. I don't even want to go through that bullet because we hardly ever start warfarin in these patients anymore because we have the DOACs. So here's the two different types of assays. You're probably most familiar with the ELISA. It's very quick. It's a screening assay. It's highly sensitive. So if you get a negative ELISA, you can be very confident your patient doesn't have HIT. But if it's positive at all, there's going to be a reflexive better assay, which is the the serotonin release assay on the right. It's both highly sensitive and highly specific. It only picks up pathogenic antibodies. And if that's positive, then your patient has HIT and you have to implement longer term therapy. These are your pharmacologic agents that you can use to treat heparin-induced thrombocytopenia. There's a lot of them. Trivia, the only one that's FDA approved is argatroban, which is another parenteral direct thrombin inhibitor. Everything else is off-label. But the DOACs are now preferred anytime we can use them in these patients with heparin-induced thrombocytopenia. All right. So we don't know how long to treat these HIT patients, but remember, I mentioned it's an immune-mediated reaction, one of the most fascinating disease states because it's a non-memory immune reaction, okay? So the antibodies are actually cleared from the system at about 85 days. So we generally say, if you have to anticoagulate, do it for about 3 months, 90 days, and then you can call it good as long as the patient doesn't have any other reason to be anticoagulated. And if they have to be re-exposed, you can do that in a very cautious manner for a very short period of time, such as like cardiac invasive surgery, okay? All right, so conclusions, anticoagulant-associated bleeding is rare, but when it happens, you need a thoughtful, stepwise approach. Don't knee-jerk this. Judicious use of reversal, and consider timely resumption and shared decision-making with your patient. And HIT is a rare but potentially fatal condition. Prompt recognition, accurate selection of patients for testing and treatment is paramount, and you've got to be using those non-heparin anticoagulation strategies that we looked at on the last slide. I'll just leave this slide up. There's an opportunity coming up from the Anticoagulation Forum for a virtual boot camp in case you're interested. Registration is there. All right, that was a lot and it was fast. I'll start by thanking you for your attention. And then I just want to see if there's any questions. I think we have about 1, maybe 2 minutes. Yes, please. Can we wait for the microphone? We want to make sure everybody hears your question.
So for surgical patients that they usually have BD prophylaxis, patients have had a colon infection, whatever, we're looking back for 4 or 5 days. They go home, usually on the inside. Do we even need to be concerned about any reactions as it starts to happen?
Yeah, I think it's a good question. I mean, obviously, we're not going to monitor those patients continually on an outpatient basis. And it's because HIT is so rare, I don't think we would have to have a high degree of concern. And remember, it's the higher risk, the longer you're on it and higher intensity. Now, if that patient manifested with like a DVT in the postoperative period, it came back to the hospital, one of the first things I'd be thinking about is how does their platelet count now compared to when they were here the last time? And then I would go into my 4T workup. It's an excellent question. Okay. Yep, I'll be hanging around a bit. If you guys have questions, I'm happy to answer them. Thank you guys and enjoy the rest of the conference.